Hi, welcome to week 8. We are going to keep going with coagulation and go through 2 PowerPoints today. So the first one is going to be on hemorrhagic disorders, and then the second one will be on thrombotic. So kind of the opposite of each other. One's bleeding, one's clotting. I am going to share my screen. Everything's okay. I'm not sure what happened there. It just kind of froze for a second, so I don't know if you guys got froze for a second or not, but we're going to continue on. It does say it's still recording. So, all right, we'll begin with that hemorrhagic coagulation disorders PowerPoint. Put it in slideshow format. All right, so hemorrhagic, of course, means bleeding, and that bleeding could be either localized or generalized. So if we call it localized, that means it's coming from a single location. Generalized means it's coming from multiple areas. And then you can further divide it into, is it a primary or secondary? Remember last week, we learned the difference between the two. Primary hemostasis means it's just involving the blood vessels and platelets. Secondary is now involving the coagulation proteins, or what we call factors. And maybe we're missing a deficient in one of them or something like that. All right, so again, hemorrhage overall, very severe bleeding. When we have somebody coming in and presenting with severe bleeding, right away the doctor starts thinking about, okay, let's check their platelet count, their PT, their PTT. Those are PT and PTT always. They're so commonly done. Fibrinogen levels, so you can even do thrombin time. Not every place will do all that, but PT and PTT for sure are going to get ordered. And we learned that in the screening tests PowerPoint last week, so you should have a copy of that. All right, so other tests, of course, we want to check their hemoglobin levels, hematocrit, all that. If they're bleeding out, how low are those getting? Are they getting an anemia? So hemoglobin, hematocrit, retic count, all assessing for anemia, which we've learned. And the bone marrow response with the retic count. Platelet count, of course, is looking at, do they have low platelets? Is that why they're having more bleeding issues? PT, again, remember the prothrombin time is looking at the extrinsic pathway. So the extrinsic pathway is including factors 7, 10, 5, 2, 1. I know I listed it a little differently there, but that's basically the pathway in order, 7, 10, 5, 2, 1. The APTT, or active APTT, is looking at the intrinsic pathway, which is basically all of them except 7 and 13. So it's 12, 11, 10, 9, 8, 10, 9, 8, 12, 11, 9, 8, 10, 5, 2, 1. And then thrombin time, of course, is all about the conversion of fibrinogen to a fibrin clot. So if you're not converting a fibrinogen to the fibrin clot in the right amount of time, if it's taking too long, it could indicate something's wrong with your fibrinogen, whether you're low in fibrinogen, you have hypofibrinogenemia, or your fibrinogen is dysfunctional, it's not working properly, which we call dysfibrinogenemia. Again, all this was in that screening test PowerPoint with the lecture on that. All right, so there are different acquired hemorrhagic disorders and inherited hemorrhagic disorders. The acquired are listed here. Liver disease is a big one. When you think about it, all your coagulation proteins pretty much get made by your liver. So if you're having liver disease and your liver's not functioning, you're not going to make those proteins. So then you're going to have a hard time stopping bleeding as a result. Vitamin K deficiency, renal failure, acquired hemophilia, and acquired von Willebrand disease. So here's the slide on liver disease. Definitely you can see some mucocutaneous bleeding because of low platelet counts or decreased platelet function. Remember, mucocutaneous bleeding is referencing like bleeding of the gums, nosebleeds, petechiae, purpura, those like surface bleeds. You can get some soft tissue bleeding, a little bit more bleeding occurring when they're not able to make the coagulation factors correctly. So you get a little bit more than just surface bleeding happening when it gets to that point. So it kind of discusses at the very bottom there, liver disease particularly affects the production of vitamin K dependent factors. So remember, the vitamin K dependent factors are 2, 7, 9, and 10. That's what we call that prothrombin group. So, and you have to know that. I think it's on several study guides. I mean, I think I asked that question a zillion times in assignments to try to get it home. So vitamin K dependent factors, the prothrombin group, 2, 7, 9, 10. Liver disease will really affect those ones. And then it will also affect some of your regulators, proteins C, S, and Z. So as a result, the prothrombin time is definitely prolonged in liver disease because of that factor 7 that's involved, and it's really sensitive to that activity. And since 7 is a vitamin K dependent factor and liver disease is really affecting it, that PT for sure will become prolonged. We do use factor 5 as more of a specific marker to just liver disease because we're trying to sort out, is it liver disease or do they have a problem with vitamin K itself? So if you want to try to distinguish between that, factor 5 would be a better look. Factor 5 is more decreased in liver disease, but it would not be affected by vitamin K because it's not part of that prothrombin group 2, 7, 9, and 10. Just an FYI on that. I don't really test you on this. This is not something I would ask a question on. It's just informational. Renal failure. So yes, your kidneys do have some things to play here, a role to play. Chronic renal failure, definitely you'll see platelet dysfunction, mucocutaneous bleeding. Acute renal failure, you'll see GI bleeding. CoAG tests don't really point to renal failure. Of course, we have lots of other great chemistry tests for that, but just know that you can see bleeding going along with kidney failure. It's something we commonly do see, so you will see that associated. Vitamin K deficiency, so like we just discussed, there is that whole prothrombin group that is dependent on vitamin K, those 2, 7, 9, and 10. So if you are deficient in your vitamin K, you are not going to be able to make and have those factors function properly, and then you're going to result in more bleeding. Hemorrhagic disease of the newborn, HDN, was very common due to vitamin K deficiency. So they used to be mandating vitamin K shots to all newborns when they're born to kind of help jumpstart that CoAG system and give them the vitamin K they might be missing. Again, I don't know if they still do this or not. I don't know if it's absolutely mandated anymore, but that used to be the thought process. So that's kind of it there. You don't really need to, the rest is just more informational based. And then hemophilia. So we've all probably heard of hemophilia. Most of us, when we think of hemophilia, think of the inherited form, which we are going to discuss. But there are acquired forms of hemophilia. So if you were to ever form an antibody that basically targets factor 8, you could form an acquired hemophilia because now your factor 8 is not working. So if you ever form that antibody that targets it, that's when you can acquire hemophilia. Otherwise, the main hemophilias we're discussing is going to be the inherited one. So we're going to wait on this and discuss the hemophilias there. It's going to basically, the rest of it be the same information. It's just to make it acquired, you're making an antibody to attack it. In the inherited, you're obviously born with a deficiency already. So we will come back to learning more about hemophilias with the inherited. Same with acquired von Willebrand disease. You're acquiring a deficiency of von Willebrand factor. There is an inherited form of this. We're going to learn that more. So it's going to be the same kind of type symptoms and lab findings. So we'll come back to this basically. So here it is. This is the one I would rather have you know the congenital. I mean, von Willebrand disease, whether it's acquired or congenital, will have the same kind of features. One you're born with, one you're not kind of deal. So von Willebrand factor, again, first and foremost, we have to know what it does in our body to understand how it results in bleeding disorder. So von Willebrand factor, VWF, says it right there at the top. It's got two main functions. The basic primary function is to help with platelet adhesion, get those platelets to stick to the surface of wherever the wound is so that they can start to do their aggregation and clumping and form a clot. The other function is that it also helps carry and stabilize factor 8. So when you have von Willebrand disease in which you are becoming deficient in that factor, you, of course, cannot have any platelet adhesion. That's its main job. So you're not going to have a good ability to form a platelet plug. And then if it becomes low enough, deficient enough, then it will start to affect factor 8 availability as well since it carries it. So again, first and foremost, when you become deficient in von Willebrand, it will definitely affect your platelet job. If you come low enough, then it's going to start to affect factor 8 too, because that won't be available for the coagulation pathway. So definitely, because it's mainly affecting the platelets, you're going to see the mucocutaneous bleeding. Those are the main symptoms that kind of are seen with von Willebrand disease. So again, gum bleeds, nose bleeds, surface bleeding like the petechiae purpura, and some bruising. So those were going to be signs that you would see in von Willebrand disease. All right, so there are different types of disorders. I am not going to test you on the different types. If you ever look in your board study guide book, You might see questions referencing the different types. I feel like those are more of an MLS based questions. I think they assign those to the 4-year degree students. But no matter what, you'll get what you need. We're going to worry about type 1 because type 1 is the most common type. It's seen in more than 70% of people that have von Willebrand disease. The other 2 types are lesser seen, like type 3 is extremely rare. So just kind of, this is FYI if you were to ever see on the board study guidebook, whenever you get to that point, like references to different types, I think it's getting to be more of an MLS level. But for our purposes, we need to know type 1, so that is where your quantitative VWF deficiency. In other words, you don't have enough von Willebrand factor. So to diagnose this, again, you'll see the history of mucocutaneous bleeding. So a patient would come in and they would either have petechiae, purpura, nosebleeds, or that's what they'd be telling. They'd say, oh, I'm always getting nosebleeds. I'm always getting these little pinpoint hemorrhages on my skin, whatever. The doctor, if they think it's going to be von Willebrand disease, if they have a family history of it, because remember this is congenital, they're born with this. If they have a family history, that's a big clue. We could measure the level of von Willebrand factor activity in them. So that is a task we can run. We can see what is their level of von Willebrand factor, and of course it would come back and show that it's low. So you could also do a CBC, which the doctor probably would do right away, to look at their platelet count. In von Willebrand disease, the platelet count is pretty much normal. Yes, the platelets don't function well, but the platelets numbers themselves are still normal. So you should see a normal platelet count unless they have something else going on. But their platelet count should be normal, but their function of those platelets, like if they were to do a bleeding time and look at the function of the platelets, that would be prolonged. Those platelets are not working because they're missing that von Willebrand factor. And then, if the von Willebrand factor gets really low and affects the factor VIII, you would see the PTT become prolonged because the factor VIII is not available in that pathway. And so it's not forming a clot in the intrinsic pathway anymore. So that one's kind of unique because PTT could be normal if they haven't affected factor VIII yet, or it can become prolonged if it did affect factor VIII. But again, the whole key to this is the platelets function is affected, so the bleeding time would be prolonged. And then if you were to actually measure the levels, you'd see the decreased VWF level. The other thing it mentions here is ristocetin cofactor activity assay. So ristocetin is a cofactor to von Willebrand factor. In other words, both are needed in order to have platelet adhesion work. There is an ability to measure if your platelets respond to ristocetin. If your platelets do not respond to ristocetin, that's a huge clue your von Willebrand factor is affected. They go together. They are cofactors for each other. So if you're missing your von Willebrand factor, your ristocetin activity will be abnormal as well. So you should remember, anytime that you see ristocetin abnormal, right away link it to von Willebrand factor. The two go together because they're cofactors. So both of those would be abnormal. All right, switching gears into the inherited hemophilia A's. So basically hemophilias, there's going to be A, B, and C. All three are sex-linked inherited disorders. So what that means by saying sex-linked inherited is that it's pretty much just affecting males. These are recessive. It is a recessive gene. It's not dominant, so it's a recessive sex-linked inheritance. So the way that that works is that their X chromosome is abnormal. Now, with females, because we have 2 X chromosomes, it doesn't really affect us because we still have one good one. Because males only have 1 X chromosome, it does affect them, and that's why it's pretty much just seen in males. So each hemophilia, whether it be A, B, or C, will be deficient in one factor. So hemophilia A is the most common one, and that is a factor VIII deficiency. So because you're missing factor VIII, your PTT levels will be very prolonged because it's that intrinsic pathway that's getting affected. Now, the difference with hemophilias is because it's a factor deficiency, it's not going to be the mucocutaneous bleeding. That's more platelet stuff. These are just factor problems. So we are going to see deep muscle, joint, tissue bleeds. So much more significant bleeding. And if you've ever watched any medical based shows like House or things like that, I know that there was one show on USA that had a hemophiliac on there. You probably have heard this in TV shows or whatever. So those deep muscle bleeds, bleeding into CNS, GI tract, kidneys, So very significant bleeding with the hemophilias. Now, the other thing to remember is when you get a case study and it's giving you all these test results with coagulation disorders, it is so important to look at the symptoms and the history of the patient with that case study. Look at the age and look if there's a family history. So people that are born with hemophilia, it's going to be always a male for the most part, so you should see a boy. It's going to be diagnosed in childhood. They're not going to get to be 40 years old and have no history of bleeding with hemophilia. They're going to be diagnosed in their childhood, and they're going to have history of bleeding problems, and they're going to have family history. Somebody in their family has hemophilia as well at some point. So that's kind of all key to helping diagnose is, besides looking at the lab results, look at your patient, like what's the age, is it a male or female, do they have history of bleeding, do they have family history, that kind of thing. All right, so hemophilia A, factor VIII deficiency. So to diagnose it, again, usually diagnosed within the first few years of their life, history of symptoms. PT is normal. It doesn't affect anything in the extrinsic pathway. It's just that factor VIII deficiency, so it's only affecting the PTT pathway, so that'll be prolonged. Thrombin time normal has nothing to do with fibrinogen. So to officially diagnose it, once the doctor kind of knows that family history and the deep bleed history, we could run the factor levels. You can run factor VIII, factor IX, and 11 because those are your three hemophilias. And for hemophilia A, it would come back with the factor VIII being very decreased. And so that would tell us it's hemophilia A. Hemophilia B is factor IX deficiency. Remember, factor IX is known as the Christmas factor, so you can call this Christmas disease as well. Again, factor IX is also one of those vitamin K dependent factors in that prothrombin group. So again, sex-linked inherited recessive disorder, same type of symptoms with the deep muscle bleeds and things like that. Again, factor IX is only found in the intrinsic pathway, so it's only affecting the PTT test, so that will be prolonged. And again, if you were to actually measure the level of factor IX, you would see that it's really low, and that's how you diagnose. And then finally, hemophilia C is factor XI deficiency. They call this Rosenthal syndrome, and it's based on that basically most of these cases are seen in a very specific population of Jews called the Ashkenazi Jews. And so it's kind of a familial thing over within that population. So that's how they came up with the nickname Rosenthal syndrome. So again, factor XI is only found in the intrinsic pathway. So it's just affecting the PTT test. And if you're to measure the level of factor XI, it would be low. Same type of symptoms and stuff otherwise. So that is your hemorrhagic coag disorders. The most important things to take away from this is knowing your von Willebrand disease and knowing your hemophilias. So that is by far what I am going to be really focused on out of this PowerPoint. Okay, let's switch over to the opposite kind of spectrum with clotting and go to thrombosis risk testing, all about clotting. And all right, I just have to make sure I'm still recording. So we'll skip through the objectives. Of course, you can always read those, but thrombosis is a word that means inappropriate formation of platelet or fibrin clots. It's some sort of clot, whether it be platelet or fibrin-based, that are obstructing your blood vessels, results in causing ischemia and necrosis. So again, ischemia basically means really slowed down blood flow because you're starting to have a blockage, and then necrosis would be tissue death. So risk factors to forming clots: your age, the older you get, the more risk you are. Immobilization, because you have decreased blood flow then. That's why they say sitting for long, long periods of time in a car or in a plane. You should always try to take breaks or get up and walk around, whatever you can to help get that blood flow again. Your diet, of course, anybody that's taking in a lot more fatty foods, high cholesterol. Cholesterol will build up in your blood vessels when you have too much and really slow that blood flow, result in clots forming, that kind of thing. So just basically bad diet. Taking birth control, oral contraceptives, pregnancy, smoking, inflammation, the list goes on and on. All right. By the way, I'm not going to touch on that list. I think most of this, a lot of this is kind of something you probably have heard already before. So there are different diseases that occur that might also promote the formation of clots. Your myeloproliferative disorders, we just learned those a couple weeks ago. They have a higher risk of having clotting. And when you think about it, we learned in myeloproliferative that we're overly producing stuff, right? That's overproliferation. especially in essential thrombocythemia, where you have tons and tons and tons of platelets. Those platelets will get together and form a platelet clot. Or in polycythemia vera, where you just have so many cells all over, all of the cell lines are increased. Those are definitely going to promote clotting because you have a really thick plasma, platelet activation, all that stuff is happening with the overproduction. Different liver and kidney disorders because it's kind of affecting coag pathways. Cancer, malignancies, a huge risk. Leukemia, we especially learned with acute promyelocytic leukemia, M3, that was the one that really had a habit of forming DIC, which DIC, again, is clots all over the body. And the list goes on. Again, this is mostly informational here. So some congenital thrombosis. So there are different deficiencies that you can be born with. These we are going to need to know. So we're going to go through each one of these. We'll start with, we're going to start with something. Hold on one second. Let me flip through. I think, I have it later on. It's going to start over here, but we're going to start with some other stuff that's not listed right here that we do need to know. So this point forward is going to get to be a lot more important. Sorry, I just thought I had it in a different order. So first we'll start with antiphospholipid antibodies, which you can call APL antibodies. These are antibodies that you have formed in response to an autoimmune disorder. So these are autoantibodies. So if somebody has one of the autoimmune disorders, if you've been through immunology, you should know them. If you haven't, that's okay. So some common autoimmune disorders, just to list off for anybody that hasn't been through immunology, is rheumatoid arthritis, Sjogren's syndrome. Those are both listed there in the blue font. Lupus. Lupus is a big one. So anything like those three, and there's others, any autoimmune disorder, that is what is happening in an autoimmune disorder. Your body is all of a sudden decided to start forming antibodies to attack itself. Auto means self. So you have, for some reason, formed antibodies that are attacking itself and resulting in this disease. With these antibodies, they also cause a problem with our coagulation and forming clots then. So antiphospholipid antibodies are called that because they are targeting the phospholipids. Remember when we learned in the first PowerPoint last week about the coagulation pathways, and I was listing out the numbers and stuff. I think I did say there, but if I didn't, I'm going to say it now. Yes, we need to know the factors in the pathways, but I also wanted you to remember that besides all the different factors in each pathway, that you absolutely need calcium and you absolutely need phospholipids to form a clot at the end. Those are throughout the pathway. We just didn't list them specifically. Overall, we just have to keep in mind calcium and phospholipids also are definitely a huge part of forming a clot. So as a result, these antibodies that you're making in these autoimmune disorders will bind to those phospholipids that are part of that pathway. And so what we see then is the ability to form clots and happening increasingly. So because of that, you're going to see strokes happen because if a clot goes up, like say into the brain, you can get a stroke. Ischemic attacks where you have that reduced blood flow and it causes a lot of pain and stuff could result in an MI, which is a heart attack. Venous thrombosis, so if you have like a clot down in your leg or somewhere else, you know, so that whole binding to the phospholipids with these antibodies kind of triggers increased clotting, and it could result in one of those. So we would suspect an antiphospholipid antibody when all of a sudden there's just unexplained clotting happening, or low platelet counts, which means the platelets are all being formed up in that clot and we have less available. So there are different tests that we can run. One of the most common antibodies that we see that does this is called the lupus anticoagulant. It's a weird name, but it's basically an antibody that we have formed when somebody has lupus and is promoting clotting to occur. It's one of these. There's other ones called anticardiolipin. There's beta-2 GPI. There's other types of antibodies. This is just antiphospholipid is an overall category, and underneath that there's a whole bunch of different ones that are found in the various autoimmune diseases. So anytime that we see these antibodies, you should know that they have the prevalence to form clots in these disorders. All right, moving on to the next one, we have what we call factor V Leiden mutation. This is definitely something you should know about. I don't know if I test on this a lot, but what I will say is I need you to know this because you will see this at some point in your career if you work in like the general heme coag lab area. I've seen it myself in a very small town, so it's not something that's like totally like never seen. At some point, I think you would see this, and if nothing else, you might have a board question on it, as always. So factor V Leiden mutation is basically what it's called, factor V mutation. So your factor V protein has become mutated and kind of become inactivated, as you will. So, or not inactivated, that's the wrong way. Let me go back and explain. So again, protein C, we learned this in the first PowerPoint, and we learned a lot in that first PowerPoint, I know. Protein C, when that binds to protein S, those two together, the whole purpose of protein C and S is to inactivate your factors 5 and 8. Remember, they're regulators. They put a stop to your CoAG pathway, because once we're forming clots, you need to stop your CoAG pathway and say, hey, we're done, we don't need more clots. That was kind of their role, was, okay, we'll go and inactivate factors 5 and 8 to make sure we stop our CoAG pathway, we're done. Well, if your factor V gene mutates, then it can't get inactivated. It doesn't respond to the protein C anymore, so it will not be inactivated. And so as a result, it just keeps going, and it becomes active, and your CoAG pathway then just keeps going and making more and more clots. So the whole premise of this PowerPoint, again, is clotting. So factor V Leiden mutation results in clotting because it doesn't get turned off by protein C. And so it lets the CoAG pathway keep going as well. So we have just named that mutation that occurs factor V Leiden as a result. Okay, moving on to antithrombin. You can have an antithrombin deficiency. You can either be born with it or you can acquire it with different disorders. So we did learn antithrombin in that first PowerPoint. Again, that's another regulator of our pathways. And the way that it does that is antithrombin is kind of named what it does. It's antithrombin. It helps go and like puts a stop to thrombin and neutralizes it. And thrombin had a huge role in our body with a lot of factors. And then it also will neutralize factors 9, 10, 11, and 12. So it's basically got 5 things it will neutralize by using antithrombin. And then that would stop your pathways and say, well, we're done, we don't need any more clots. Well, if you're deficient in antithrombin, you're not going to be able to do that job. And as a result, your pathways keep going and you're at risk at forming clotting, excessive clotting. And then same with protein C. We just discussed this. Protein C will bind with protein S and help inactivate factors 5 and 8. Well, if you are deficient in protein C, you're not going to stop the pathways and you have more prevalent to clots. Now, there is a really important statement here that says thrombin will bind with thrombomodulin and become an anticoagulant by activating protein C. So that's how protein C first gets activated, is when you're going through this CoAG pathway, thrombin will also bind with a substance we call thrombomodulin, and that activates protein C. That will bind with S, and then that is what goes in and activates 5 and 8. So that's the whole process. Well, again, if you are missing protein C, there's nothing to, bind to S then, and nothing ever gets inactivated for 5 and 8. So that's where the increased thrombosis comes in. I would say I would definitely remember that second bullet point there. That is an important statement. All right, so lab approach to thrombosis. We're going to see the prevalence of clotting. If they can't figure out if it's due to a specific disorder, then maybe we can measure. We can measure levels of protein C, measure levels of protein S, measure levels of antithrombin, and see if one of them is decreased as well. There are arterial thrombosis, of course, not just venous thrombosis. So again, same kind of thought process of what happens to form arterial clots. I'm not going to go through this right now. It's informational. I'm not going to test on this. A lot of it's just high cholesterol again, things like that. So, all right, so we're just going to kind of skip through these. These are readable if you want. I'm not going to test. But if anything, we do have to know DIC. We have learned DIC in Hematology 1. You probably don't remember it because a lot of times by this point people forget it. We've heard about it a few times since then. Now is the time to remember it. You cannot forget it anymore. So DIC stands for disseminated intravascular coagulation. So the name coagulation tells you it's about the clotting. So we are intravascular clots. So you have clots occurring inside the blood vessels. So when we learned about DIC, it was when we learned the MAHAs in Heme 1. And MAHAs were microangiopathic hemolytic anemia. So that was the one where you have clots occurring in the smaller blood vessels. That's where the microangiopathic name came in. So like the arterioles, the capillaries. So you had to have small blood vessels getting kind of occluded and blocked with these clots. So basically, because they were just the smaller blood vessels at first, you wouldn't have any symptoms or signs that that was happening. And you wouldn't know because it's just the small vessels and your main vessels were working. Until you had so many built up, then you would result in one big hemorrhage because there was nothing left to clot. So DIC, always an emergency situation, always a huge, huge thing. It is never something that occurs on its own. It's always secondary to another disorder or condition the patient has. So the patient will either be having a difficult pregnancy, if they have a sepsis, so like a really bad infection, if they have leukemia or cancer, those are all things that promote DIC to occur as a secondary to that condition. So just know that it's something that just happens based on some sort of condition or thing that they have going on, and it triggers these small clots to start being formed. And when you're making all these small clots, you're using up your platelets in the clots, you're using up your coagulation proteins and fibrinogen in them. So you're using everything in your body that you have to form clots because you're making them all over. And then that's what results in all of a sudden you have one big hemorrhage because nothing is left anymore to stop you from bleeding out. So it uses everything up, and that's why it's such a serious, dire situation. So as a result, we definitely see FDPs, fibrin degradation products, elevated. So fibrin degradation products, remember, are those little pieces of clots that come off, and we can measure them. You can either do a fibrin degradation product test, or the common test to run is what we call D-dimer. And a D-dimer is specifically looking for that piece of product off the clot, known as a D-dimer. And if that's positive or elevated, whatever test you're running, if it's positive, it tells the doctor, yeah, you have a clot or clots. It doesn't tell the doctor where, it just says, yes, these are present. So D-dimer will definitely be positive here because obviously they have clots happening quite a bit. So other ways to diagnose this, remember, since everything is getting used up, everything is going to be out of whack. Every test is kind of out of disorder. So you're going to see low platelet count because all your platelets are used up in those clots. You will have prolonged PT and PTT because all of your coagulation factors are stuck up in those clots and there's nothing there anymore. Again, that elevated or positive D-dimer is huge because that tells you there's clots present. If you were to run a fibrinogen level, that would be low because all your fibrinogen is used up to make fibrin clots. If you were to run a thrombin time would be prolonged because, again, that's measuring fibrinogen to fibrin. There's nothing there. It's all used up. If you were to run a bleeding time, well, if your platelets are all used up, there's no way to measure anything for bleeding time. So that would be prolonged. And then if you were to look at the blood under the smear, because this is an intravascular hemolysis type situation occurring, you're going to see schistocytes. Remember, schistocytes always went along with intravascular. You'd see the low platelet count as well on the blood smear. So the nice thing with DIC is just know that all the tests are kind of out of order, all of them. So again, there's lots of different causes of why DIC would occur, but again, it's always secondary to at least something on this list or more. And then finally, we have heparin-induced thrombocytopenia. I would know this as well. This is basically if somebody was forming clots, they might be put on heparin. Heparin, remember, is a blood thinner, so that would kind of help their body stop clotting so much. So it's just therapy that they get for forming clots at some point. The side effect of being put on heparin is that it affects their platelets. It actually decreases their platelet count. And so a lot of times when people are put on heparin, we monitor their platelet count to make sure that it doesn't get too low because we know that heparin will affect it. So they might do more platelet counts quite often just to make sure their platelet level is still a little bit decent. All right, so that is it in that one. Some big disorders in there as well to know. If you guys have any questions, as always, please feel free to reach out to me. Otherwise, have a great week. Thank you.